my grandfather was a doctor, and I used to hang around my grandfather's house all the time, and he would tell me stories about medicine, and he would quiz me all the time. And it was an amazing way to learn. And so that's kind of the way my brain thinks. And I think it's, it's a great way to learn medicine, because, textbook just isn't going to cut it for you. You need to have live interaction, and you do need to be, kind of put on the hot seat a little bit, because those are the things you remember the most when somebody's pimping you and asking you questions and things. So again, please don't be insulted. When I ask you your level of education, I'll try and direct my questions to that level. If you want to, say, uncle, give it to somebody who's a little more experienced, I'm happy to pass it up. And let's just have some fun with this and kind of free float. And we could look at one CAT scan for, 30 minutes going over anatomy, or we could go quickly through a case. And what we'll do is we'll shoot to hit a couple of cases and have some interaction. So let me ask for a volunteer for the first case so we can jump in. Cephalus, where are you from?
So I'm go to St. George. I'm in my second year, and I'm actually from the Toronto region of Ontario.
Excellent. All right. Tell me what you know about hydrocephalus.
What do I know about hydrocephalus? So we said that the cerebrospinal fluid is filtered through the arachnoid granulations. You can have congenital hydrocephalus, and basically it's just when you get obstruction. You can have communicating hydrocephalus, which is where you have all the ventricles dilated. You can just have hydrocephalus in one of the ventricles. So usually that's caused by obstructions, maybe within the cerebral aqueduct. So you would get, I think that's probably one of the most common places, as well as the foramens of Luschka or the interventricular foramen. And generally, like you said, with congenital hydrocephalus, they place a VP shunt to sort of drain off that fluid. That way it gets reabsorbed through the peritoneum if it can't be reabsorbed through the arachnoid granulations. That's all
Good.
I can think of at the moment.
Good. So breaking it down simply, there's obstructive hydrocephalus and there's communicating hydrocephalus. So obstructive hydrocephalus is when the cerebrospinal fluid that's produced in the center of the brain from the choroid plexus can't get out, and it can't get around to percolate around the brain and the spinal cord. So there's an obstruction at the level of the foramen of Monroe, an obstruction at the level of the aqueduct, an obstruction at the level of the fourth ventricle. And then if it's not obstructed, it's communicating. That means the cerebrospinal fluid is going through all those pathways. It comes out, it percolates around the surface of the brain, and it doesn't get back into the bloodstream through the arachnoid granulations. The arachnoid granulations typically sit along the superior sagittal sinus region, and the cerebrospinal fluid by bulk flow percolates back into the venous system, and it's reabsorbed. We make about 500 cc's of spinal fluid a day. We absorb about 500 cc's of spinal fluid a day. If for some reason we don't absorb exactly what we produce, we begin to develop a buildup of fluid, and that's called communicating hydrocephalus. So the arachnoid granulations can get clogged, basically. What happens is when either there are tumor cells in the cerebrospinal fluid, which can clog the arachnoid granulations, just like leaves clog the gutters of your house. Tumor cells can clog the arachnoid granulations, or red blood cells can clog the arachnoid granulations. So sometimes when there's a trauma and there's some subarachnoid blood, those red blood cells, when they get to the arachnoid granulations, they can cause scarring and a buildup. And that can happen in children, and that can happen in adults as well.
Sacrum and the pelvis. And I have a couple patients I'm working up right now who I think that's probably their pain generator. It's like an impingement or a pseudo fusion of that. I think it's underdescribed and underreported, but there's a couple things that I'll look at in that scenario. And the lateral, I like to see the femoral heads to be able to identify the pelvic incidence and do a lot of the lumbar measurements for deformity. Basically, the amount of curvature you have in your lumbar spine should correlate with a fixed number, which is called your pelvic incidence. And you use the center of your femoral heads to line up to the sacrum. And that can just tell you sometimes if a patient has lost some of their curvature. If you're going to plan on doing surgery, you may want to plan a little bit of correction into your surgery. And that helps me for planning purposes. So if I'm definitely planning for surgery, I'd love to be able to at least see the femorals. I think you can see almost both of them here, so you can take the difference from that, and that's good. I try to identifying your structures like your pedicles is 100% the right way to go. And on the lateral, I'll take some extra time to look at the bodies of the vertebra and just make sure I don't see any kind of lytic or blastic lesions or anything that could be concerning for an incidental finding, because you will find patients. The more patients you see, you will find patients who have an underlying tumor or cancer that you will be the first to diagnose. And it's not fun, but you may see something that's concerning, and it may be consistent with the patient's symptoms.
NeuroRounds has provided me the opportunity to push myself outside of my comfort zone and to practice applying knowledge in novel situations in an environment that is challenging, but at the same time supportive and constructive. I'm someone that normally doesn't speak up right away, but through these months of NeuroRounds and on rotations this past year, I've made it a point to always push myself to be the first one to step in and say something, knowing that I have that internal hesitation. It's a wonderful environment to practice confidence, because the rewards you gain from overcoming that fear are not only personally satisfying, but immensely powerful in terms of how much you will actively engage with the material and the amount of confidence you can move forward with in your rotations down the road in your medical career. NeuroRounds has been a fantastic opportunity to practice the application of knowledge, and I'm thankful for Dr. McLaughlin and Maggie's help throughout the whole process.
So what kinds of questions would you ask the emergency room doctor?
So I would ask if they're stable, if their vitals are good. And then depending on what the CT scan tells us.
All right, let's say we're going to show you the CT scan, but what are the questions you've been sleeping too? You woke up on the phone, the phone rang and you picked it up. Before you even look at the CAT scan, what do you want to know? Vital signs, good. What else?
Okay. So I guess you said already how long ago this happened.
Good. Time of event. What about the headache specifically do you want to know? And I told you.
Where the headache is, I guess, the location of it.
Always helpful to know where it is, but I told you a piece of information that was important about her headache. Do you remember what it was?
It was 9 out of 10. Pain.
Yes.
Painful.
And when did it happen?
It happened right after the fall.
Exactly. Okay, that's always a very important piece of information. You want to know, did she have a headache before she fell, or did she have a headache immediately after she fell? And sometimes people don't know that. So good. Intensity of the headache, vital signs. Did the headache happen before or after the fall? And then the ER doctor tells you, she's kind of goofy. I don't know. I don't know whether we should admit her or not, or maybe we can repeat the scan. What do you think?
Probably admit, but what do you mean by kind of goofy, I guess?
Exactly. Exactly. All right. You're going to get a lot of people who inadvertently kind of dumb down an exam. And I want you all thinking critically. It's your job on the neurosurgery service to be thinking of the worst things that this could possibly be, and also to kind of lead people in being precise in what they tell you. Test on the left.
So if he's been standing or running for a while, does he obtain relief by bending forward?
He does.
Or John, you're nodding your head. What's the significance of that?
I was about to ask if he had shopping cart signs. So that would suggest neurologic claudication.
Tell people what shopping cart sign is.
So if there's spinal stenosis in a particular region, and if a patient feels relief with bending forward, this would relieve compression on that particular region, from what I understand. Whereas if you had exaggerated pain with leaning forward, I think that would suggest vascular complications.
Exactly.
Nile, you got a question?
Yeah, hi. This is just a general question in terms of the surgical technique. So you said the C5, the arthroplasty is the more newer technique and the ACDF is the gold standard. So how would you go about deciding between the two? Is it true that mostly the younger patients would be offered the arthroplasty or ACDF, or is it the other way around for older patients? Like how you decide between the two?
Sure. I prefaced it with
Can I try to answer, Dr. McLaughlin?
Sure. Go ahead.
So typically you'll order a CAT scan and an X-ray flexion extension to see if there's any significant movement. And if there is instability, I'm not sure if just one level you would do the ACDF, but 2 levels of instability, you would likely do an ACDF to prevent adjacent segment disease down the road.
Excellent. A little bit more. So any instability is a contraindication for a disc replacement. So if there's abnormal movement of that joint, you're going to need to fix it, because that means the abnormal movement probably caused the disc herniation, and putting in a loose device is just going to fail. So any instability, we're not going to use it. If there's a lot of arthritis in the facet joints, it's not worth putting in, because there's not going to be a lot of movement in the joints anyway. So generally younger person, anybody 50 and under, I haven't placed many in people above 50, but if they have good range of motion, there's no instability, they are a candidate. Now, keep in mind, this literature is still emerging, but there's no definitive study that says arthroplasty is a better long-term solution than anterior cervical fusion. It's theoretically the case. Physiologically, it makes sense, but we're still following the literature on that. I think if it were me, I would want the arthroplasty, because you burn less bridges. You can always go back to a fusion if you have to. But again, it would depend on having minimal arthritis in the facet joints and no movement. But that was a good question.
I love everything about neurosurgery except paperwork. I am the worst person in the world about signing notes. And now that I'm in a chief position, I have realized I can't yell at the people who work with me unless I'm doing at least as well or better than they are at getting my paperwork done. So it's been a life-changing event.
It's interesting just hearing, I have so many questions for you, but it's interesting just hearing that, along the way, you found your way to neurosurgery because you loved it. And one of the points that I think it's really important for the students to hear is that you're going to hear all kinds of rumors about whatever you want to go into. Oh, those people have this or that. And of course, I sent you, some of you may have seen the new TikTok video with that funny comedian doctor doing how to ace your neurosurgery interview, where, it just makes a joke of neurosurgeons that we're all irate, arrogant, divorced, don't know our family kind of people. But really, that's not the case, because you're looking at a bunch of doctors who are on this call who are, happily married and have wonderful families and know their children. But also, it's really important to do what you love. Like, there's so many people told me, oh, neurosurgery, you're never going to have a life. You're not going to be able to do the things you like to do. You got to go with work-life balance. And the fact of the matter is, you got to go with what you love. And if you love what you do, you're going to make everything else work. Have you found that the case? And what are your reflections on that?
Yeah, so I think that, there are some very wise people who talk about the fact that if you love what you do, it's not work, it's a career or a vocation. And I totally aspire to that. And, you know, when I get medical students or other people who come to my office and say, you know, well, I want to do X, Y, and Z. And so how do I set up my whole world? I'm like, well, have you considered A, B, and C? Because what if you love those? And I think it's really important to take that opportunity, especially, I mean, I look at my own self and how I was just bound and determined. And I was on this path to do, you know, this practice in neurology and discovered I hated it. And thank goodness I changed my mind, because I'd probably be out of medicine by now if that's what I had done. So I think you've really got to be true to your calling.
So one of the questions that we had was, if we could put an electrode into sensory cortex, could we restore sensation? And would that make a difference? And so with a little luck, this will also play. So in this case, what we did was there are sensors in the fingers on this particular robotic arm. So this is Nathan. Nathan wanted to be a biomedical engineer before his accident.
Thank you.
So the audio doesn't seem to be working, Elizabeth, but
Oh, okay. So he actually, so the thing that's very cool is that he actually is able not only to identify each finger correctly, but he's able to identify pairs of fingers. And so I'm going to stop sharing my screen at this point, because those are sort of the wows. The goal, the idea there was, okay, well, if we can restore sensation, can we actually improve function? And what we found was, if we have these participants do sort of standard occupational therapy tasks where they're picking up an object and moving it, if you just using your vision to do it, you can perform pretty well. But if we add the sensory feedback, and we think it's just simply knowing that the hand has come in contact with an object so that you know you've hit it, you can almost perform these tasks at the speed of an able-bodied human. And so we've now been able to demonstrate that there really is a value of adding this sensory feedback to the system. And so Jan was only implanted for a little over 2 years. Nathan has now been implanted well over 5 years. We have coupled with the University of Chicago. And so we now have two additional subjects who have been implanted and a third one on the way. And so, you know, we're still sort of a novelty. And I always explain to people that before this is really truly going to be a technology that is applicable to a large group of people, we have to have this so that many places are comfortable with implanting these electrodes and doing it successfully. And I say that because we know there have been research programs that weren't successful. And so one of the things has been trying to understand, why have we been so successful? And have I been able to now pass that on to the other surgeons who are doing the implants in our study, so that we can then figure out what those pieces are we need to take back to other programs and teach them, so that we can have 20 sites that are doing this, so that we can move to the point where this is going to be a real valuable clinical tool.
That is so cool. Question for you. How far off are we from where somebody could get this electrode placed above, outside the skull vault, just basically, you know, in the scalp, or maybe in the future even wear a hat, put on a hat that basically will allow something like that to happen? How many years do you think it's going to take?
So one of the big challenges with doing something that's not invasive is really knowing, you know, what can we decode, how precise can we get with that information? Because if you think about it, when you're looking at an EEG, you're looking at the responses of thousands of cells at each contact. And so the answer is, how much data do we really need? We did some work with ECOG grids, so putting them in the subdural or the epidural space. And we know that we can do some degree of motor control. We did not manage to do 10 degrees of freedom, but we were able to certainly do 3-dimensional control. So there's a little bit of understanding the science. There's a little bit of the technology. When we look at the ECOG grids, none of the companies that currently make ECOG grids were interested in getting into the field of long-term implants. Medtronic has the appropriate grids that are available for long-term implant, but sometimes doing research with a really big company has its challenges, especially if you're a little teeny group and it sort of becomes, is the tail wagging the dog, or is the dog wagging the tail? And so but there are now some other companies out there that have embraced this and are really working on developing some devices that will lend themselves to being clinically marketable. So I think we're moving closer. I think we will have implantable devices that was essentially where the batteries and the communication sit with the skull, probably within the next 2 to 3 years. I think before we actually have something we can just put on somebody's head is going to be probably more like 5 to 7 years out.
Who wants to take it away?
Remember, best student wins a free pair of Joe's Crazy Socks.
Dr. McLaughlin, I can take a stab at it.
All right, go for it, John. Who's on?
John is. Hi.
Great. Go ahead.
So first of all, I see the question in the top right corner. So this looks like the sagittal MR image of the lumbar and sacral junction. And I know that we talked about last time I was on, the spinal canal itself, or the spinal cord, ends at L1, L2. And so down here in this region, it wouldn't be impinging on the spinal cord itself, but it looks like the spinal canal region with the cauda equina is being encroached. And it doesn't look like the vertebral bodies are aligned necessarily as appropriately as I would think. So it looks like L5 is displaced posteriorly a little bit.
There's a name for that. Do you know what that is?
Retrospondylolisthesis?
Spondylolisthesis, yeah.
Okay.
It's actually an anterolisthesis. It's forward, not backwards. You can have a retrolisthesis, but that would be a posteriorly migrated area. Excellent job.
Yeah.
Anything else you see? Anything else you want to comment on?
Well, this looks like it's a T2 weighted image since the spinal fluid is bright.
Good.
And it looks like there's some loss of signal at that region between L4 and L5 within the column.
Good. So again, we talked about being systematic when looking at a film. You want to go from left to right, and then you want to go from top to bottom. You've gone left to right pretty good. How about top to bottom?
So looking at the vertebral bodies superior to it, it looks like the actual discs themselves are being compressed, or they don't look as robust as the ones inferior to them. That would be at between L2 and L3 and L2 and L1 as well.
Yeah, they're all pretty ratty looking, aren't they? I don't know if you can see my cursor, but the best disc actually is the one that's got the spondylolisthesis. All of these are collapsed. And, we have a saying in neurosurgery that gravity is undefeated. This is the result of gravity and wear and tear. There's an anterior osteophyte here. All right, good. Is Dr. Kalia still on? My illustrious chief resident?
I'm here, Mark.
Kamal, this is an 86-year-old guy with a L4-5 spondylolisthesis and neurogenic claudication. How would you manage this person? And by the way, he's got pretty significant scoliosis too. I could show you an axial image, but in the interest of time, he's got pretty mildly severe scoliosis, which you can see.
Yeah, so Mark, I really struggle with this every case. I can't share my screen, but I have up, some 2 articles in the New England Journal of Medicine, to fuse or not to fuse. So in general terms, I would tell everyone this is probably one of the most common. I have office hours today. This is probably going to be the most common thing I deal with all day long. It's very, very prevalent, and we really don't have great guidance on what's the right thing to do. So in simple terms, you have this hallway, the nerves are running in the hallway, the floor's buckled up, the roof's caved in, and all the nerves want is some more room. And so there's simple ways to make more room. One way is just to remove a little bit of the roof. But, everything in the spine has some structural importance. So you start taking away things and you may weaken that structure. So this is where the dilemma comes in. When you start cutting things away, are you going to weaken this spine to where it's going to fall apart, which then leads to the question of, in these cases where you have a narrowing of the spine, stenosis, and you're going to ectomize something, laminectomy, facetectomy, etc., are you going to destabilize or make the patient's pain worse because the spondylolisthesis gets worse? And quite frankly, we don't know the right answer. There's a lot of opinion, and it's really that. So you and I both have to do our board maintenance of certification, and they have a nice study guide there. There's 2 conflicting articles, one showing an advantage to fusion and the other showing no advantage to fusion. So when it comes to something like this, I think, if this patient sees 5 different neurosurgeons or orthopedic surgeons, they may get 5 different opinions. In my practice, I try to do the least invasive, simplest thing that's going to help the patient.
So this is really what it looks like in the OR. Instead of me looking through the microscope, we have this sterile device that kind of looks like just a camera that's sitting there, and I'm using 3D goggles to look on the screen. And on the screen, I can see what's going on, and I'm not looking at the patient's wound. So it's a little bit of a learning curve to kind of get used to it. But we ended up able to do the surgery down to the blood vessel. And then because I'm so familiar doing it with the microscope, I wanted the microscope for the final movement. But what you're looking at, I think, is a great advance. It's not going to totally supplant the microscope, I think, for deeper cases, but it works very well. We trialed it on the spine, and it works very well on the spine as well. And so that's a new type of technology called an exoscope, and I wanted to share that with you. So we kind of reviewed our series here at Central State since 2013. We've done 81 of these microvascular decompressions, and Maggie is looking at the results now, and we're hoping to publish a paper on this sometime in the future. All right, so we're going to come out of this presentation and let's fall back into NeuroRounds. I know it's a little bit of a change up for you. I hope you enjoyed that. But not far off, it's actually being able to do remote surgeries, walking doctors through operations. Brian's always pointed out that there are a lot of surgeons out there that kind of know how to do an emergency operation, but maybe don't know the full steps. And with a little guidance, a mentor, they could probably do these surgeries. And if you look at the global, population of surgeons, there's a tremendous dearth and a tremendous need for surgeons out there in third world countries. And I think this is a technology that can certainly help them. So we're going to jump right in. We're going to show some live videos today. And thanks for getting up early and getting involved. Ask questions. The dura, sometimes there's no way to get it free without tearing the dura. John, you agree? You had those experiences where you've got a facet joint that's just literally infolded into the dura, and the only way to get the decompression done is usually a small compromise of the dura.
Couple of comments. One, in that situation, sometimes you have to just leave that go around it and then just take it off without actually attacking that area. But sometimes, as a old neurosurgeon used to tell me, the operation will declare itself in terms of what you need to do. Another comment just about dura in general, I agree with everything you said, but one thing I would add is it's not so much likely in this case where it's a small area, but if you're doing an extensive or a very long operation in terms of time, the dura can dry out. And in that case, it gets much thinner, much more friable, and much more susceptible to tears or rips. So you have to be very conscious to keep the dura moist, or at least protected by those cottonoid patties, which are wettened and on top of it. So you always got to be conscious of it during any of these types of operations.
I'm just curious, how many other specialties are you going to get involved with her before you operate? Are you going to have oncology see her? You're going to have other specialties input? Because, that adds time, especially in this era, with what's going on in medicine. It takes so much time to get people in to see physicians.
That's a great question. And actually, I did get oncology to see her. And I also got a general surgeon to join me on the case, because it's sort of, it's kind of on the borderline of being a general surgery case, a surgical oncology case in my book. And I thought it would be good to have them, although I think this is, an area that we're obviously comfortable with. I wanted to have them on board in case they had any other ideas. I definitely wanted to, keep this capsule intact, because we didn't want to have any local spread if it happened to be something more aggressive. So that's a really good question. And, I'm sure you do this too, is, I called the oncologist and I said, you need to see this person in the next week. And they were pretty good about it. And I called the general surgeon and I showed him the films, and he's going to just assist me on the case. So I'm glad you mentioned that. Always good to have this is on the border of two specialties, folks. And when that is the case, you want to bring in some other people too. Sometimes they'll have another thought. And in fact, I think the oncologist wanted to do a PET scan, and that was negative. Good morning, everybody. I just want to echo Maggie's comment. Don't be bashful. The best way to learn and the best way we can get a good discussion going is for you to step up to the plate and try to answer some questions. We're not going to embarrass you, and I promise you that when you're getting what we call pimped in the medical world, those are the things you remember the most. It truly is the way you learn. So let's get started. Maggie, just let me know if Dr. LeMaison jumps on, because it'd be interesting to have him talk a little bit about his new book if he jumps on. Okay.
You got it.
So we've got our resident orthopedic surgeon here joining us today, Dr. Tydings, and I'm trying to advance my slide. Here we go. Let's try again. There we go. All right. So this is a 39-year-old woman who presents with severe neck pain radiating into her left and right arm, with some tingling and numbness in her hands. It's been going on for 4 months. And she has some clumsiness in her hands, trouble with buttoning buttons, and some fine motor movements. Walking is fine. Bowel and bladder function is fine. She's had physical therapy, and that made it worse. And she's had one epidural steroid injection, and that equivocally maybe made her slightly better. And she's come to our office today. And this is her scan.
Yeah, that's a good question. I do think it's partly because of the way that I'm wired. I do like to take the initiative when given the opportunity to, but also as I've been learning throughout my rotations is that I benefit greatly by being put on the spot, whether it be like asked like, oh, like what is your plan with this patient? Or can you read this x-ray? So I choose to take charge and attempt to answer Dr. McLaughlin's questions because it helps me learn. I'm also a big believer that I'd rather mess up now as a student when it's okay to mess up and learn from it so that I don't make the same mistake again when I'm the one in the hot seat making those decisions. I do notice that it has helped me greatly, like when I'm in the hospital and I'm able to like read x-rays or MRI, CT scans a lot faster. And especially with patients that present with neurology-based presentations, I'm able to pick it up faster than my colleagues. So I think I have benefited greatly from it. No, I mean, my only hope is that more people would participate because it makes the whole discussion flow better. And that if everybody would like have their cameras on and stuff. I mean, on Dr. McLaughlin's end, I can't think of anything I would change.
Andrew, there's a treasure trove of information in what you just expounded on. I want to point out just a few interesting things, and I have some questions for you. So, one, you were interested in being an astronaut and then a biomedical engineer. Engineering, in my opinion, is harder than medicine as far as like getting through it in college. And engineering, I think, is definitely harder than pre-med. And then you ended up with neurosurgery. It's interesting. It reminds me of Dr. Haid, who just spoke at the American Association of Neurological Surgeons, and as he was just finished his presidency. And one of the things he asked of all the neurosurgeons was to close your eyes and ask yourself why, like in the truest and most basic sense, why did you pick neurosurgery? And we also sort of sat there for about a minute, and everybody's thought about their mentors, and everybody thought about, the experiences they had, and all those things are part of it. But he stopped everybody and said, I'm going to bet that every single one of you maybe didn't think of this, but it's one of the number one reasons. And he said, that's because it's hard. And certain people like to do hard things. So it's actually no surprise to me that you were interested in doing other hard things, and then you came upon this hard thing to do, and you went ahead and did it. So I think that's really cool, and it shows it's a testament to your character that there's something in you that wants to do something really hard and technically challenging. So that was one thing I wanted to point out. The second thing is, one of the goals of this NeuroRounds is for people to see, hear, and touch neurosurgery, because it demystifies it and it gives people access to it. You can't imagine what you're going to do unless you actually get to see it and sometimes be around people who do it. Like if you look at Olympians, like the chances of Olympians having parents who are Olympians are very, very high, because it's normal. It's normal in that family to be an Olympian, and they have a genetic predisposition, but it's also a mental barrier that they already have seen broken. So it's really awesome that you pierce the veil of medicine and neurosurgery in your family. I was lucky. I had a couple of doctors in my family and one neurosurgeon. So in some respects, it was already a reality for me that it could happen. So one question I had for you is, everybody generally sort of points to one or two experiences that they had that said, wow, this is what I really, really want to do. And it almost always centers around a person or an interaction. And if you can, do you have an experience like that? I remember for me, it was working with Dr. John Pavlichak and just being in his lab and seeing his passion for neuroanatomy and his quest for knowledge. And that just totally inspired me to go into neurosurgery, even more than, my uncle obviously was an inspiration to go into it, and my other uncle was a general surgeon. But really for neurosurgery, it was John Pavlichak. Did you have an experience like that? And what was the actual trait or quality that they exhibited that made you say, wow, I want to be like that person?
Yeah, I think there's a couple of experiences. One of my mentors, Dr. Sean Hervey-Jumper, while I was doing research at UCSF after my M1 year, I think the characteristic traits that I would say I would like to emulate is just the great compassion he had towards the patient and his ability to maintain his youthful energy in terms of being excited about what he's doing every day. I think that passion is contagious, and I think it inspires people. And so that's something that inspired me personally. And I would like to give that forward, whether it's to future residents or medical students or whatever it might be. And so that was the positive side of it. I think something that also helped me realize the severity and breadth and depth of what we as neurosurgeons are going to face is just that when things go wrong, there was a case, it was a foramen magnum meningioma that was completely compressing the spinal cord, but the patient came in essentially intact except for mild symptoms. And so a decision was made to operate and try to remove the tumor, and the surgery itself, because it was very hard to visualize any anatomy, it was very hard to visualize the vertebral arteries. And essentially what ended up happening is the patient had equivalent of a locked-in syndrome where they were unable to move anything and can only respond with their eyes. And so to see the patient come in, she was a little bit anxious about the surgery and nervous. And then to see that outcome, I think really made me realize the decisions that we make carry heavy weight. And I think that's a big responsibility that shouldn't be taken for granted. And so I think the two sides of those, really positive highs and the really low lows, I think made me appreciate what we do.
So just a little bit about aneurysmal subarachnoid hemorrhage. It's a bad disease. About 10 to 15% drop dead. They don't make it to medical care. That's about on par with a massive MI if you suffer it outside of a hospital. Up to half of patients die within 30 days. And of those that reach a hospital, the classic a third, you see this comes up in medicine all the time. A third do well, a third do poorly, and a third die. Okay, so it is a nasty disease, and that's why we take it so seriously. An aneurysmal subarachnoid hemorrhage should trigger a reflexive mechanism that you want to work fast to help this patient. And the main concern is that once an aneurysm has bled, the risk of it rebleeding is pretty significant. So if we say 4% chance of it bleeding within 24 hours, 20% chance of it bleeding within 2 weeks. But the main thing to appreciate is that if that aneurysm rebleeds, up to a 70% chance that you're going to die from that rebleed. Because the brain can tolerate one injury pretty well, but the brain cannot tolerate multiple repetitive injuries in a short period of time. That's why repetitive concussions are so tragic and cause such severe brain injury. Same thing with the rebleeding of an aneurysm. 70% mortality if that aneurysm is not identified and fixed before it will rebleed. And a misdiagnosis of a subarachnoid hemorrhage is a real problem. In my world, in the neurosurgical world, at least outside of spine, actually including spine, the two most common litigated events in an ER in our world is missing a spinal epidural abscess and missing a ruptured aneurysm, missing an aneurysmal subarachnoid hemorrhage. So this is really practical information for anybody that works in any hospital, any acute care independent facility or an emergency department, okay? So this was a great study that looked at 4 huge centers and found that about 1 in 4, 25% of ruptured aneurysms were missed. And if they were missed, most of those went on to rebleed. And if they rebled, 3 out of 4 of those patients died. So this is serious business. And the number 1 and 2 reason why those aneurysms were missed is because subarachnoid hemorrhage was not on the differential. If someone comes into an emergency department, or if you have a friend that tells you, I have the worst headache of my life, once again, the first and only thing that should come to the top of the list is a ruptured aneurysm. The other reason that these aneurysms were missed, 1, because it wasn't on the differential, but 2 is because the head CT was normal. And this is fairly common for 2 reasons. If you drizzle food coloring into the subarachnoid space of the brain, you know, the brain makes about a soda can, about 350 milliliters of CSF every 24 hours. So it's going to wash out that food coloring. It's going to wash out that blood the longer you give it. So if someone has a severe headache on a Friday and finally comes into the ER Monday, Wednesday, or the following Friday, a lot of times that blood can have been washed out from all the CSF your brain is making, and the CAT scan may look normal. So you have to have subarachnoid hemorrhage high in the differential. And a lot of people will have what's called a sentinel headache, a moderately severe headache, or the worst headache of their life, and then it rapidly gets better, and then the headache comes back days to weeks later. So some people will present in a delayed fashion. So it's got to be on your mind at all times for those coming in with a severe headache or the worst headache of their life.
Good morning, everybody. Welcome back. I hope you had a good long weekend and you got a full head of steam ready to roll. So, Maggie, tell everybody about where you are and what's going on and what happened in the last 7 days.
Yeah. So as you all know, I've been with Dr. McLaughlin for around like 5 years, from a shadow to working for him to being his right-hand man. I'm in my second year of medical school at St. George's, but I got a last-minute research position in a neuroscience lab, and it was required for me to come be here for 4 weeks before my last term starts. So I sort of had to pick up my whole life and move to Grenada. So this is our first NeuroRounds with me being international. I know I saw Chris on here. He's been to Grenada before. So I'm acclimating. It's definitely a big change, but like Dr. McLaughlin said I think it was last NeuroRounds, when you get an opportunity, you sort of have to take it. And I took it, and I'm going to engulf myself into it. And I've had a lot of emotions and fear and being scared and leaving your family and leaving my comfort zone, but I'm really excited for it, and I'll keep everyone updated.
Maggie, you had a lot of trepidation even telling me about this. Tell the audience about what you were thinking, and then, what my reaction to it was.
Yeah, so I was definitely nervous, just because, again, I've been with him, Dr. McLaughlin, for so long, and we have such a good, flow of how we work together. And I was just a little disappointed I had to leave him and leave behind the good work that we do together. I was sad, really sad. But I sent him an email. I had to be really transparent and honest, because we had to get things figured out as soon as possible. So I sent him an email. He was on vacation, and I laid out everything that was going on, and I got nothing but the amazing support. And he told me that, we'll figure it out, and don't be sad about leaving, be excited. And what he said to me the other day was, make 2 publications make 2 publications 6, make 4 learning objectives 10. And I think my favorite thing you said to me was, a good mentor. What was it? A good mentor
hopes you'll move on.
Hopes you move on. A great mentor knows you will. So that really stuck with me. And, just having a supportive mentor is really important, because I had a lot of anxiety, is I think the good word about it, of leaving and the changes, and how he would figure out how to get a new person, and if they would mix well with them, and if they, fill my shoes, sort of.
Well, just so proud of all your accomplishments, and so happy that you continue to move on. Just for everybody out there, if you're working in a lab and you've got somebody who's been an advisor for you, and you get an opportunity that's better, that's going to help you more, if that person gets mad at you for more than like 20 minutes, they're not a good mentor, because they don't want you to advance. They want you to do their work. So have an antenna out for that. Somebody who's really interested in your best interest is going to support you 100%. If you think it's what you need to do to advance your career, you should be getting support from that person, not negativity.